Hello, Leanne and John. You're muted.
Hi, John. Hi, Kim. And here's Matt. This is wonderful. And Ellie is on.
Hello.
Great.
Everybody.
Yeah, this is wonderful. So we're going to wait just a few minutes until we get some more people on. I've got about 5 or 6 people that have said they were going to be coming. And so I'm very excited about that. Ellie has San Francisco behind her. She's actually in Minnesota.
Yes,
Oh.
I am. I pretend a lot.
You pretend, okay. All right. How are you doing, Matt? Oh, you're muted too.
I try to mute so I just don't interrupt anything. I'm doing
Yeah.
well. I'm really glad to be here. The first time I was invited, I wasn't able to attend, so I'm glad.
Yeah, well, I'm so glad our last month got some IT problems and we didn't end up being able to have it. So I'm really glad that you're able to be here. So let's
How are you
see.
feeling, Leanne?
I'm much better. Today I feel like I got some kind of a terrible inoculation or something. My arm feels like it's been hit. So don't know why. Let's see here. Now I've lost my Zoom and David is David Asseto, my friend from Kenya, and he is a nursing student that's about to graduate.
Yay.
Yeah, so I'm going to go off. One of the things we would like everybody to do is go into the chat and put your name, phone number, email, and where you live, what state at least that you live in. And then if you want to add any information about yourself, that would be great too. I'm going to find my notes here and put them in the chat. Let's see here. Okay, that's interesting.
Yes.
I may have to go away here for a little bit. Put that down.
Welcome, Denise.
Hello. John, how's the book coming?
Very slow.
Oh, it's a lot of work, eh?
I just haven't had time. I'm swamped again at work and
Mhm.
60-hour weeks and
Yeah.
Story of my life. But I like paying mortgages and car payments and college and all that stuff.
Uh-huh. I'm glad you like doing that.
I'm lucky. I love my job, so
Okay, I think I'm back here again. Let's do this. I got you up here. Okay, so I'm going to put these messages in the chat here too, so that if people are coming in, they can find out the information. Let's see here. We should have put those in there separately. Okay, so anyway, the 3 things I wanted to get in there are there. If you want to, write down the Zoom link will be the one that we'll be using going forward until January. Hi, Denise. Glad to see you. I think we can probably start. For anybody who didn't hear before, if you can put your information in the chat, your name, phone number, email, and where you're living. That would be great. This usually is a meeting that goes pretty quickly and there's a lot of information exchange. We want to make sure we hear from everybody. So we will do just a quick introduction, maybe just 30 seconds to a minute, and tell us, who you are, what you're doing, and what brought you to being interested in Nurses Transforming Healthcare. So we can just go around. I'll just start. I'm Leanne Meyer, and I started with doing a podcast or an international talk show for nurses that was called Once a Nurse, Always a Nurse. And I interviewed the 3 other co-founders of Nurses Transforming Healthcare. So Kim Evans is up in my upper corner, and John is in the center for me. John, I was thrilled to meet because he has an economic plan to help us move from business for a business model for healthcare that is mostly about making money to a service model, which is mostly about having good health outcomes. And so that's 2 of the people. Kathleen Bartholomew is not able to be with us today. Kim, I'll let her introduce herself. So I've got a lot of calls coming in on my phone, so I'm going to see what's going on there.
Hello, everybody. I'm really thrilled to be here today. I'm Kim Evans, and I'm one of the co-founders of Nurses Transforming Healthcare. And I just have had a passion to transform healthcare because I've seen it so broken in the last 50 years. I started when I was 5. But anyway, I have an integrative medicine clinic that after working as a critical care specialist and seeing all the things that, that could have been prevented, I dedicated my life to wellness and prevention. So I started my integrative medicine clinic in the year 2000, and it's grown ever since then. So I'm just thrilled to take it to a bigger platform so that we can truly transform healthcare, because it so needs to happen. So I'm very happy to be here and to meet each one of you and see some of you that I've met before.
John, do you want to tell us a little about you? Oh, you're muted. You're muted, John.
I'm old, so there's a lot to tell, but I was, this is my 51st year in healthcare, actually, practice in multiple states. Saw the commonality of the problems, especially geared toward nursing at that point. So when I went back to school, I just kind of suddenly dawned on me that the problems with the system, we have the wrong system design. So I started thinking about how to approach that, went into my PhD, traveled around the world, 3 continents, studied health systems, and came back and after developing what I thought you had to start with, which is what are the goals you're trying to accomplish? I just eliminated models that didn't meet those goals and ended up with a public utility model, which met all 7 goals. So I started going on podcasts, and that's when I did Leanne's podcast. And then I met Kim and Kathleen, and we said, hey, let's try to get this done.
Wonderful. And we can talk more about the plan that the model that he came up with. Let's see, Denise, can you share a little bit about yourself? And you just mentioned that you are somebody that any of these people can connect with also with the work that you're doing. If you want to keep going. Okay.
Yeah, thank you for that, Leanne. So Denise Wiseman, and if we're doing short, concise, I'll just say that I have co-founded with 2 retired physicians the Healthcare Reinvention Collaborative. Our mission is to identify, connect, support, and illuminate the healthcare change makers, who I lovingly call ruckus makers, who have a shared purpose-driven vision for what healthcare could and should be. So I get asked often, how are we going to reinvent healthcare? And I say back each time, our mission is to identify, connect, support, and illuminate those change makers who will reinvent healthcare. So HRC won't do it. We're going to enable each of you to do so. I put my information in the chat, so please check out our website, reach out. I'd love to talk with you.
Excellent. Thank you so much.
She and her group are amazing, by the way.
Thank you, John.
Yeah, just doing amazing things and really helping people who want to do this transformation work find each other and talk to each other. Matt, can you tell us a little bit about yourself?
Yes, I'm a bedside nurse, and the short and skinny of it was I got burnt out in the COVID, and then I just started asking questions. And luckily, I was pointed in the direction of your organization. But like, I have researched my own like ideas of what's going on. But as a keynote speaker, I go around and I speak about bedside issues, and we talk about overcoming like the stacked deck against this. And what I want to see is a level playing field. And the more talking about it, the more I realized like that level playing field is going to come from an organizational structure standpoint. So I can't believe I'm in touch with a venture capitalist group that wants to actually start a hospital, that actually wants to follow your model. And I cannot believe that people want this.
Yes, this is wonderful. Ellie, can you share a little about yourself?
Sure. I'm Ellie LeClaire, and I've been in Marin for over 55 years. And I like this type of model as well because in things that I have done in the past in all those years, it's always treating people who already have problems. So to look at diabetes, for example, or hypertension, heart failure, it's always trying to fix what they came in with instead of preventing further complications from happening to keep them out of the hospital and to help them have a quality of life. Currently, I am out there working with community, and I also want to look into and am looking into nursing homes and assisted living in order to teach about dementia, to provide information, workshops, because that too is a disease process that people don't always look at those subtle initial kinds of signs and symptoms that could prevent a person from going into the hospital, ending up in a nursing home far earlier than they really, quote unquote, need to. So I would like people to, understand a little bit more and then a lot more about how they can protect themselves and also look at their loved ones in how they can uh, diminish the risk factors, because you can't cure dementia, but you can diminish the risk factors and have people still have a quality of life.
Thank you. That's great. Ellie just lives down the road from me a little bit. We've got a dog. Yay. Let's see. Darlene, would you like to tell us about yourself?
Good morning, everybody. Well, I'm joining you from just outside of Edmonton, Alberta, Canada. And ever since Nurses Transforming Healthcare was started, and my co-nurse and myself, we were starting a group in Alberta called Nurses for Transformational Healthcare. And again, similar but different. We're in different countries, so the systems are a little bit different. But bottom line is I'm a neuroscience nurse. That was always my thing, from the bedside to the boardroom table. And you're right, Ellie, all that work was always about fixing broken brains and bodies. And yes, we did amazing work. But now my whole work has shifted upstream to building better brains and bodies. And so it's like, we always say we don't have a healthcare system, we have an illness care system. And so we need to change that. And things are a little bit different in both of our countries, but that doesn't mean we can't learn from each other. Honestly, I've used your books, Kathleen's, and yours as well, about I was guest lecturing again in a nursing leadership or nursing research. Used your stuff again, your lovely book. And Kathleen's, and I'm doing a talk on a summit with a nurse from Vancouver with about 24 other speakers. And my top, that one, that one, Transforming Healthcare, right? Use it all the time. And my topic is going to be why exactly from the Dauntless Nurse about why communication skills are as important as clinical skills for nurses. And it's just, they go hand in hand. And we usually don't teach the communication skills, which nurses need at any level that they're working in within the healthcare system.
And especially conflict communication skills,
Yeah.
which does
Yes.
not get taught either.
Yeah.
Let's see, Lillian.
Good morning. And I am also another Canadian here with Darlene. I'm in British Columbia, in Canada, in Lake Country now. I used to live in Kelowna. And I met Leanne a few years ago now. And I think we're like sisters from another mother. 23?
2023.
Okay. That's wonderful. And I just love this group and have so let me just give you a little bit of my background. I was an LPN, as some of you would know. I was an RPN in Ontario. And I worked with oncology patients mostly. Loved it, loved the bedside. I stepped away from it to look after my family and get into restaurant business and pharmaceuticals, and I've done a whole bunch of things and discovered coaching. And so what I do is I work with the nurses who are in that place of close to burnout or burnout and help them to look after themselves first so that they can show up here and help us change healthcare. So that's what my role is. So if you know any nurses who are looking for that, and I'm just about to launch officially Join the Movement Nurses Reclaim Life. It's a group that will be doing a complimentary free for 2025. And it's a place where they can come weekly and we can talk about what's working in their life. Let's celebrate those things that are working. And if there are any challenges, how can we all help them and support them?
What's it called again, Lillian?
It's Join the Movement Nurses Reclaim Life. So if you look at it, Alive in Healthcare is the name of my company. I'll send you out some information when I'm prepared to launch that. And and invite anybody who's interested to come to that group. So excellent. I'm excited to be here.
Yeah. Liz, can you share about yourself? And you are muted.
Hi there. Sorry I'm not on camera here. I'm doing this from my phone. But yeah, my name's Liz Weiner. I am a Body Talk practitioner, which is a mind-body healthcare system, and my background is accounting before that. So I'm in Southern California and just very interested in what you're doing. I'm interested in improving healthcare, making people healthier from a wellness perspective, from just getting their bodies to work better and having the type of work I do be done alongside conventional care. So
we want that collaboration. Absolutely.
Yeah, absolutely. So I really appreciate what you're doing.
Thank you. David, can you, I don't know if you can put your camera on, but can you unmute yourself and tell us a little bit about who you are?
Hello, everyone. Okay, I'm Aseto David from Kenya. I'm a student nurse. I will be doing my licensing exam by August, and I will just love to learn more from you people. I thank you so much, Lynn, for the invite. Be blessed.
You're very welcome. Thank you. David and I, oops. Was there something more?
No.
Oh, okay. There's some noise behind you if you want to mute yourself again. Thank you. David and I met several years ago when he had completed just 1 year of nursing, 1 semester of nursing school and was hitting roadblocks. So I've been working with him. So what I'd like to go back to, since we probably have everybody in here now, to talk about what is the core of who we are and what we're trying to do. So what we want to do is to transform healthcare to a model based on wellness and disease prevention, driven by nurses, which is affordable and accessible to all. We say driven by nurses, but we want to welcome in other people from other aspects of healthcare. We just feel like the nursing theory is a good place to work toward health, not work toward sickness. So we just have done, are kind of coming to the end of a long period of reorganization. And what we're doing the point that we're at right now is we're trying to find people that are passionate about what it is that we're doing also and would like to be a part of it by being either a committee leader or a committee member. And I'm wondering, Kim, would you like to say a little bit about that, what we're looking for? Would you like me to say it? I can do that, but
I'm happy to. Thank you, Leanne. Yeah, we did a little reorganizing. We had suggestions from a consultant that said we needed to be a little more structured and organized if we wanted to be in a better position to allocate for grants. And so we did that. We rewrote our bylaws and got a little more sophisticated in the organizational structure. So, you know, for those of us who really like to build the plane as we fly, it was a little bit daunting because I'm more of a doer. At the same time, we are now in a good position to be able to apply for grants and have an excellent structure to move forward. So we understand the undertaking, and I'm so thrilled to hear from Matt today. I want to hear more from you. But what we know that we can't just immediately change a healthcare structure that's so focused on profit-driven and disease care and immediately turn that around to a wellness and prevention model. And so our vision all along has been to put in switch tracks so that we can kind of mold it to our eventual goal of a public utility model. And so one of the ideas that we've had is a campaign called Flip Your Zip campaign. So that if we could take a zip code that has horrible health outcomes and put in nurse-run clinics and models, and then shift that healthcare and let that be a model for the rest of the country, then we could do this and eventually grow it towards a public utility model. So that is the overall vision. And yes, Emily Spinsky is our new president, who's done a phenomenal job. She's a nursing professor in New Hampshire and just dynamite. And so, you know, we feel like we're in a really good space to, again, move forward.
excellent. So I know several of you have not heard very much about the adapted public utility model. Is that something that we could talk about since we have John here? It's wonderful. This model to me is so important. One of the things, I mean, people across the country and around the world are trying to transform healthcare, but the one thing nobody seems to be doing is to try and have an economic model that is not the one we have now, that is not working and is not sustainable, especially in the chaos that we're going into. So John, could you share about the model and why you think this is the Flip the Zip? We're starting that as a project, but we think that project can take us to the point of being able to utilize this model.
Oh, sure. I mean, the two basic models that are out there are taxation, which we see in a lot of the OECD countries, the developed countries, or basically charity, private pay, or some kind of insurance system, which we see in the other countries. I want to go back to Canada for a second because one of the things I think people have to realize is that geography plays a huge role in what a potential solution can be. When I went to Germany and studied their system, overwhelmingly the people I talked to were pretty satisfied with it. It's basically a mandated insurance type environment. But we have to realize that Germany's smaller than Montana. And so when you put 42 million people in something the size of Montana, it's a lot easier to have distribution systems and access points. You know, Singapore gets held up as a great model. But again, we're talking something that's smaller than the boroughs of New York. So the commonality of Australia and Canada and the United States is we have these huge geographies with a lot of disparate rural areas and smaller communities that also need coverage. And the problem when you have federal systems running things is that they're slow to respond. They're not really good at responding, you know, even within a year to changing demographics and changing needs in communities. I've found going through the countries I went through that there are basically very poor assessment models. So one of the things we had to develop here was a community assessment model that was primarily nursing based. And the reason that's important, there's a couple of reasons. The first one is that 95% of the care a community needs is nursing care, not medical care. And if we start shifting health patterns, there's going to be more nursing care and less medical care. Not that medical care is not important. You still need access to that too. The other big thing is globally, women are overwhelmingly the determinant of the relationship of the family to health systems. And nurse practitioners, which the United States is lucky to have an army of nurse practitioners, and that's growing all the time, sets us apart from a lot of the rest of the world. We still are stuttering and spurting through trying to get independent practice in a lot of places. But we do have that force we can bring to bear, and especially coming up with innovative solutions for a lot of the smaller and more rural communities and a lot of the inner city areas that aren't economically, strong enough to have a lot of insured people. So I guess I could leave it there for a minute. Can't hear you, Leanne.
Does anybody have any questions they would like to ask to get more information about this? Or I guess what I'd like to say might be helpful, John, is if you could share what would this model look like as far as how it would be paid for, and how would it get those decision-making ability to closer to the people who need them?
Sure. So it's called an adapted public utility model because, as you know, in a lot of public utilities, it's based on user fees, and that's what drives it. But there are utilities that are not paid for that way. Transit systems, for example, water. These things have to be available 24 hours a day to people, based on human need. I mean, you need this stuff. So the way it's paid for in this is that we all pay. We just pay a lot less than we're paying now, and we get much better outcomes. So it would be like a utility bill, and you can base it on a lot of different things. Home ownership is one of them, or rental or home ownership. In other words, by residence, you can do this. The federal government's still going to pay, but it's going to pay a lot less. So when I did I had to stop and get an MBA cert just to, get a grasp on economics. And I worked with two economists back in the early 2000s. And we found out that, there's about a 42% reduction in cost if we shift over to this model. And cost is something else to understand because we really do not know how much it costs for healthcare. The prices have been so grossly inflated based on profiteering in this arena that it's really difficult to determine, how much everything costs. But we estimated there'd be about a 42% reduction in cost. So the government still pays into it because healthcare is a national security issue. We found that out in the Afghan or the early 2000s, when something like 65 or 70% of the applicants that volunteered for the military were incapable of being enlisted because of health concerns. It's a state issue, so the states are still going to pay. States currently average around 20% of their budget for health services, so that would drop down to around 10%. Businesses are still going to pay. If you hire 10,000 people into a community, you're impacting the healthcare for that community. But whereas a major corporation now pays about $26,000 per employee, they'd be paying somewhere around $1,000 or $1,500 into that coffer for their state-based regional health system. Small businesses would pay less, of course. Cities would still pay, but a lot less. Counties would still pay, but a lot less. And then us as individuals would still pay, but we'd be paying a lot less than we're paying now. So when you add up healthcare costs for most individuals, it not only includes their health insurance, but also their Medicare deductions from checks. So if we can reduce that amount of money we're spending significantly, everybody benefits, and then we benefit from having an actual health system versus, as what's been pointed out, a disease management system.
It looks like Matt has a question.
I just wrote in the thing, it's my understanding you're going to need at least minimal like county level government buy-in to establish that first model. Am I right though that there's no actual healthcare system in the United States actually following this model?
There is none that I'm aware of. The state-based regional councils would be made up of the practitioners, each of the specialists. I put nursing as the chair of that committee for philosophical reasons mostly, in that we're not really self-interest as much as interest in taking care of our patients. There would be a representative from the governor's office on that council, but they'd be non-voting. It would also bring in academics, EMS, public health, so that, because we're the practitioners, we understand what we can do and what we can't do. And we shouldn't have things imposed on us by a system that does not understand what we do and what we can do, or governments.
There are a few isolated programs that have kind of developed this on their own, like in a city. Ashtabula, Ohio is one I love to say, and it was the first one that I heard about, in which a group of people at a school system were realizing they were paying phenomenal amounts of money to keep to buy insured healthcare for their employees, but their employees were not well. And so somebody came up with the idea, let's hire a nurse practitioner to take care of all of our employees, and we will use the money we would have been paying into insurance to fund this, and then buy some kind of extreme, if you had a car accident or, needed major surgery or something like that. So they started that. It ended up working beautifully. So then the people in the police department, fire department, et cetera, in the city wanted to join in. And then pretty soon it was other people in the community also who were joining in. So I'm not sure exactly where they are at. And I know there's also another, I think it's a town also on the East Coast that has done something similar to this. And then there's a group called the Rosetta Group, which are really promoting this kind of care. They have sort of an insurance kind of thing, but it's based on, having people at the center of it who are actually doing the care, providing the care. Darlene, you have a question or a comment?
Yeah, and John, you're absolutely right that, part of our issues in both of our countries is the geography. So when you mentioned Germany, like you can put 3 Germanys in the province of Alberta alone. So, this is something that is, a huge thing. And one of the things we're dealing with, in Canada is exactly that, rural versus urban. So, for example, in Alberta, we had moved to Alberta Health Services. So, one big organization that was going to look after everything. But, the problem is that what's happening in Fort McMurray is completely different to what's happening in Brooks, Alberta. And this rural and urban thing is a whole nother issue. So it's, things are changing, and things are where we're looking at, how we have to design things is, and I put in the chat the link to Cormac Russell's work. If any of you are familiar with Cormac Russell's work, it's about asset-based. You start the development in the community. And when I think to what you did in Texas, you know, in that little, you started in that little community and it was their needs. It didn't matter what was going on in the rest of Texas. But again, what are the needs of the people and what do they have or not have in access to that area? And, you know, when you think about the size of, you know, the you know, each of the whole country, you're thinking, well, how will we ever get this done? And so I guess that's the big thing, but at least getting things done in the community that's going to help them. You have to start somewhere. It can be overwhelming though, but I just want to say kudos to starting something and using a model that at least, and so again, Leanne, I'm thinking, so if you've got another group that's using like the Rosetta group and stuff like that, like, do you collaborate together? Do you talk to each other about what is or isn't working? Because I think that the thing that concerns me then is that how do you get the funding? That's always been a challenge. You know, where does the funding come from?
Yeah, that's one of the things that we're working on. We have a whole committee for funding and we're looking for somebody that's what they do. And we have several people that have expressed some interest, so we'll be pursuing that. And they are looking at it from the standpoint, not just constantly looking for little dribs and drabs, but really looking at how do we get a solid base, you know, and those people who really do want to support it. Lillian, did you have something you wanted to say?
Yeah, sorry, I can't find my hand.
Oh, okay.
It's not there for some reason. But
Your
anyway.
own works just as well.
Yeah, it's true. Yeah, I was just thinking about how, you know, I'm going to be working with you guys on the videos and how to advertise this more and talk about it more in the social media aspect and interviews and things like that. So I just want to give a heads up to people who don't know that. But I was looking at the angles we need to approach this with. So I love the fact that there's a benefit to the users in the fact that there's prevention. It's all about starting. I love what you know, is happening with the clinics and things like that. But that's one angle. The other is the cost, which is important, even though it's the benefit to the end user. It is a different angle with the cost it's going to be. But another thing that we're not, I know it's in the back of our mind, but when I think, and I remember hearing this, I think from somebody on social media, Rebecca Love, I think it was, talks about, you know, when you get a hotel room, you get a maid with the hotel room. And it's the same thing in the hospital. When you get a hospital, you get a nurse with the bed kind of thing. We need to switch that mentality. And I think that's part of what we need to advertise also is nurses are not being used at their full potential. We need to change who we are as a profession. And that in itself gives us the power to start doing things differently. Give us the responsibility or at least the participation into changing healthcare, into what could be better. So I think angles are really important to get buy-ins from whoever's listening, whatever angle they need to hear. That's just my perspective.
I suspect that nobody is going to give us that. It's going to be nurses and whoever else goes with us to stand up and say, we need to create this, we need to make it work. And that's a real big mindset change. We're going to have to change how nurses are taught. We're going to have to change how medical and all of the different areas that contribute to health. Liz is one of the examples where she's working from an area that's not necessarily thought about. When we think about bringing healthcare people together, we want those people to be involved also. I'd like to see chiropractors, dentists, you know, anybody who is not now seen, Rolfing, you know, some of the other things that we don't necessarily, we have divided off from healthcare. It needs to be part of it. In just a minute, I'd like, Kim, if you can talk about what we're doing with New Hampshire University to start this whole thing. And Denise, you had your hand up. So before I go to that, do you want to talk about that? What
I
do you
appreciate that. I just wanted to make an observation because, of course, with the work that I do, I'm aware of and seeking collaboration with a number of different organizations. So when I think I'm listening to John talk about, and I love what you said, John, 95% of the care needs in our communities, a nurse can be that that first line, the right line to go to. And yet, when we think about the work that I'm doing with Medicine Forward and Primary Care for All Americans, they're very physician focused. And too often I get that there's this battle between ARNP or PAs giving care versus MDs, and we're fighting against each other. Where what we really need to be able to do is recognize the role and the position we each have in. Connected, though, we're not alone. We cannot do this alone. There is the time and the place for each of the specialty skills. But when we're refusing to give ground and to partner with, we are our own worst enemies.
Right.
And so that's one of the things that we keep talking about is how do we bridge and build unite the silos, right? Instead of standing firm where we're at. John, I saw your hand go up.
Yeah, I saw that too.
No, yeah, and it's not just, we're still evolving out of this militaristic perspective in healthcare of officers and enlisted men. And that's because a lot of the advances in nursing came during wartime, of course, and we're still evolving that. And also problems are political. So having an administration who also sees healthcare as kind of this militaristic structure, doctors being more important, other people not being able to contribute, and then the political system writ large in the country and in states also reinforces all of this. It's a real obstacle for nursing to kind of stand up on its hind legs and say, we have stuff we can bring to the table too, and it needs to be considered. The silos and the disciplines are a problem. The silos between, because each discipline sort of thinks it knows best, whether that's medicine or public health or nursing really is not put out any kind of major message as a profession saying, hey, this is the model that we'd like to work for, work towards. So we've been kind of mutes in the background. Like I say, it's difficult to break those disciplinary and political barriers.
But what makes it break is one, the system we have is broken and falling apart. People are searching for something. And if we can provide something that says this could be possible, we know it isn't going to just start, in the whole country. It's going to start, we believe it'll start one zip code at a time. So Kim, would you tell a little bit about what we're doing in New Hampshire?
I will, but before I just had a comment in terms of how to bridge the silos, because I love that concept, Denise. But in my own practice, because I have an integrated medicine clinic that I do myself and with 2 other nurse practitioners. And so what I've found is that when we reach out to physicians or other, providers, that's what really helps to create the collaboration. And, the system, as Leanne said, really does not make that very easy. And traditionally, the system, I feel like, has, as John mentioned, been more militaristic. But we just keep trying and we keep reaching out. And, even I had a patient that we sent to a cardiologist this past week, and the cardiologist told her, every practitioner needs to practice like Kim. And I was just like, he said that to you? So it is possible, but it takes a little work and a little effort to create those collaborative angles. So,
and then you're stuck with the reimbursement model that exists, So you either have to make everybody self-pay, or you have to work through what insurance is going to approve and what it isn't going to approve. And that is by and large driven by the political relationship of medicine to healthcare.
And AI now is having a huge part of it too.
Does it ever?
We don't even have intelligence in healthcare. What good is artificial intelligence going to do us?
Well, not that bad, but
hey, Matt, I would really like to follow up and talk to you about that. about
Mhm.
what you're looking at.
Yeah.
Yes, I am too. I'll share a little bit about New Hampshire, and then yes, I have a couple questions for Matt as well. So in New Hampshire, again, based on kind of what we did in Spicewood, we found a community. That's what Darlene was referring to, what we did
Texas.
in Texas. And it's a rural community that had really no access to health care. And so, we had a very passionate nurse practitioner who went into that area, and through Helping Hands, it basically started as a Helping Hands clinic that started as a food pantry. And she just started doing assessments of social determinants in the food pantry and realized many needed health care. So it all evolved from there, to give you the backstory. So from that model, then Emily has created, as a nursing professor, because there is a small rural town in New Hampshire outside the university that she works in. And so they set up this structure where one semester the nursing students would go in and do an assessment to see what are the health needs in that area. And then the next semester, the student nurses would go in and actually do some health teaching and teach some health modalities to that area. So this is the model's kind of created over a 2 to 3 year process using nursing students to help drive it. So,
And they're creating a template that then could be utilized in any university across the country. And it could be probably not just nursing and public health, but also medical and any of the other areas that want to look at it from this standpoint. So, and it has to be done in a certain way because of the universities. They know what they need to do to have this template be usable by more than one area. So we think that is what's going to help us to spread it. Once it's working in one area, it will be a lot easier to encourage other people to put it together too. And then it's going to be putting our data together. We have a few people that are interested in data. One that's worked around the world, has published many books, and he's very much interested in compassionate care, and he's also a nurse. He was one of my students. So, Kim, you wanted to ask Matt something?
Absolutely, Matt. I'm like on the
I'm
edge
ready.
here because I heard you say you have a venture capitalist who's interested in starting a hospital based on nursing, a nurse-owned. You can say more, but what I'm envisioning is a nurse-owned hospital that could be focused on wellness and disease prevention. And I'm your neighbor. I'm in Kentucky.
Are you? I've been focusing on coalition building. I don't post about it. I'm pretty heavy on LinkedIn. What's amazing is when you ask for help, people just show up out of the woodwork. That's how John and I met. And then I started reading Kathleen's papers. And I'll tell you, I'm connected with everyone, I feel like. But you've got to understand, like, and I'm not a detail-oriented guy, but I can see like a vision, like a future. I'm more of a futurist apologist. I call myself a nurse apologist. But the the real movement is developing a healthcare system that is by nurses, that is led by nurses, and just give us the keys to the kingdom and see what we can create. And you've already talked about the collaboration of it. And I think the key to bringing nurses together is to give them an even level playing field, seat at the table to where they can fully develop their nursing models. And it's like we've had for so long a fractured ecosystem where one pits off of the other, and we need to be together. And politically, like I'm preparing an open letter to Robert Kennedy or Kennedy. Which one is he?
It's
I can't
Robert.
check.
Yeah.
Thank goodness. Sometimes I say the wrong words. But in that, I've talked about some of the basic key nurse drivers that we need to be focusing on. We all talk about safe staffing. We all talk about environments where we have the opportunity to thrive, and we talk about safe environments where we're free from harm and injury. But on top of that, I think we need a reimbursement model that nurses get paid for what they do based on their profession, not just the room rate of the bed, which pulls in, the Coalition for Nurse Reimbursement. But we also need to be established as a science, which is we're not a part of STEM. And if we have an organization that's actually doing it in the country that's non-for-profit, there are the investors that want to do the model. As much as your theory is on point, John, everything you wrote is amazing. Kathleen is probably one of the most intelligent apologists for your movement. And Leanne led a public, podcast on it. And I'm sorry, Miss Evans, I've not really seen your work, but it's like you guys have potential. And it's like bringing that coalition is going to be key, I think, in breaking down those silos. And I don't know. I'm a reluctant fool, but like I think I have the ability to do some of this. You know?
No, Matt,
Interesting that you
the
said
key.
that you just sent a letter, because yes, the nurse practitioner in my office, who does have some key connections to RFKJ, also just authored a letter this week to send a copy of Kathleen's article by design and a copy of the Transforming Healthcare book. So, yes, if we could collaborate on those intentions, I really do think there is possibility to at least explore some different models.
That's why I've always believed, to break down those barriers between ourselves, those silos, we all have to agree on what we want to accomplish with a healthcare system. And we've never had, I've never seen that with a clear delineation of goals of what a healthcare system should be. I'm not talking about, a hospital and some satellite offices. I'm talking about a national goal-oriented health system where everybody understands what it is we're trying to accomplish and then gives us the innovative power to figure out, because I mean, let's be honest, we can't build a trauma hospital every 50 miles in this country. We can't even build a major hospital every 50 miles. 40% of Texas doesn't even have a primary care provider.
Yeah.
So how are we going to do that and staff it? So we have to be realistic in the solutions that we can present. Maybe that's mobile clinics. Maybe that's just getting a footprint in the community and rotating services in. I mean, whatever we need to do to deliver the access that we feel needs to be delivered and that they want to work with in a given community. And if we don't start there, if we don't start agreeing on what it is we're trying to do, then it's always going to be each discipline kind of has its focus on what it wants to accomplish, whether that's for itself, its prestige, or whatever. So that to me has always been the critical discussion we have to have.
I want to mention, it looks like Ellie wants to say something, but I wanted to mention that I did put in the chat. We have a form. It's called an interest form that is available for anybody who is interested in seeing what we are trying to do and what are the things we need. It will share our committees, what the charges are of those committees, what it is they're trying to accomplish. And then we're looking for chairs and we're looking for people to be members on those chairs. So things that people might be interested in. If that's not you, then anybody else you can connect us to that you think might be good. This is just so important that we get these truly thinking people that can lead these committees and communicate with other people, etc. Ellie?
I agree with John, and I just want to add a little bit as it comes to a few things. One is we do have a shortage of nurses as well as physicians and others out there in the healthcare field. So looking at, having the buy-in by patients themselves, we need, as you were saying, how are we going to get the nurses and get them at the table, as you're saying, to tell them that when they're earning their $60 an hour plus per hour at a hospital, treating patients who are sick, how are we going to convince some of them to work with working on a preventative model for X amount of dollars or zero. So again, who are those nurses? Because I hear talking about nurse practitioners, PAs, that sort of professional caliber. And where is the licensure? Has that been looked at? Because does the Board of Nursing ever look at increasing the ability of the nurse to perform different tasks that were not included in that overall licensure? For example, I can't administer medications because I'm an RN, I'm not a nurse practitioner. So getting the board on board too with what nurses are able to do based on our licensure, because I don't want to get sued, neither do any of you. So looking at, how we protect ourselves while we're trying to help.
Those
We do care.
big questions and very important questions that will have to be addressed as we go along. Where we get that, I think it's almost going to be kind of like happening simultaneously, and that's going
Well,
to be
speaking
interesting.
as a direct nurse educator, I've been educating nurses since 1999. We don't really present the opportunities for a lot of our students to explore other arenas besides hospitals.
Yep.
This is one of the reasons we have to tie in academia to the state-based regional councils so that the entire system becomes open to clinicals for not just nursing students, but med students. So they're actually going out and delivering care in rural communities and
Exactly.
poor communities. They're not just, medicine is basically a med school somewhere to university, and then you go to a suburban or urban hospital where you do your internships and residencies. There's no exposure to rural health. We don't expose our students to a lot of being able to do clinicals in a lot of these health clinics. So it's not just the fact of what the Nurse Practice Act says, it's what the universities themselves are willing to focus on in the education of the nurse.
Kim, I know you're just
Yeah.
jumping in there.
Well, the other interesting point is that I hear what Ellie's saying, that there appears to be a nursing shortage. However, another book that I was an author on, Healthcare Transformation by Sharon Weinstein and Dina Redinger, several authors contributed to that book. And what became very clear is that there is not a nursing shortage. It's just a lot of nurses have left the hospital systems, and some of the work be due to the working conditions. So if we had another structure that really allowed nurses to practice to their full extent, many nurses would come back in a heartbeat. And so, I think that we have an opportunity if we create a model that is pro-nursing. I think that could really take off.
I'd also say that nursing publicly has taken a big hit on a couple of fronts. One of them is not just COVID, but there's been a lot of press about nurses striking and how overwhelmed and burned out nurses are. We have a lot of nurses that are quitting. The work by the ANA to mandate the BSN into practice has really been damaging to our ADN programs throughout the country. Um, so, and let's be honest, when I taught at one of the universities I taught, we took, I think, 80 students. We had over 600 applicants. There's just not enough BSN programs in this country, even though they've converted a lot of the community colleges to BSN, to meet the demand. So shooting these ADN programs in the foot, which the ANA has been doing for 50 years, is just makes no logical sense whatsoever. And the article I wrote about it, Completing the Circle of Nursing, we've also pulled a lot of nurses out of clinical practice as they've developed themselves and become nurse practitioners. And, it's something like 360,000 nurses over the last 20 years have moved out of direct care in a hospital and are now nurse practitioners, which may still be working in a hospital.
We're coming to the end here. We've got just a couple minutes left, and I know Denise, you had put something in the chat about an event that's coming up. Do you want to talk about that?
Sure. So HRC does a number of different events, but we do a public event once a month on key topics. We've got 3 individuals who are joining us next week, the 17th, on the topic of how the hell did we get here? So they're talking about those drivers that have shifted our care to where we currently are. We'll do a follow-up in May. May 28th will be the now what? What are those solutions? So John, there's one that, well, exactly what everybody's talking about on this call. That's a perfect place to be. But the biggest thing with those events is drawing people together. We focus on making connections. So I think it's a great topic for those on this call. If you can join us, it does get recorded. So if you register, I send out the video as well as the summary, so you can still get some of that information. And then, of course, if you're able to join us for the follow-up on May 28th.
What is
Yeah,
the
you know,
date again,
I know you
Denise?
know. Sorry.
Kim, do you want to ask your question?
What is the date again? How the hell did we get here? What is
Is
the date?
next week, the 17th, 11 a.m. Pacific Standard Time.
Okay, John.
Denise, I know you know Todd. I love
Yep.
Todd Otten.
Mm-hmm.
But I was also working with a couple other physicians besides Todd. All of them agree that the model I'm talking about, the goals, all of this is absolutely right. But not one of them is going to go public because of
Yep.
the crap they're going to get from other physicians.
Yep.
Because I talk about empowering nurse practitioners at a national level.
Yep.
So, you know, that's another one of those kind of silo problems that we have to look at.
Yeah. Well, it was one of the reasons, John, I was on their traction team is what they called it, kind of their leadership team for quite some time, but I resigned at the end of last year because they're absolutely dead set firm physicians.
And they can go that route.
That's
I
right.
think it's ultimately, you know, going to end up somewhere where we are now, where, you know, those physicians, it's wonderful, but they can't practice alone. If we
Right.
don't have those people that support the patient from the patient level, and then, you know, having those collaborations, if we don't have that, you know, I was saying 5 years ago, without nurses, there is no healthcare. Well, I don't know that that's true, that I feel that way anymore, but I do feel that nurses have to be a vital part of the healthcare because of what John says. 96% of the interaction that people have with healthcare comes from a nurse.
Matt, one little thing. There are examples of how this model works all around the world. They're just not all put together anywhere. So you know, Costa Rica tied in public health with medicine and had dramatic results. Jamaica has the parish nurse, but they don't empower the community health workers to work with them, and they don't have the infrastructure, the medical system behind them really supporting them. So whatever country you go to, they have little snippets of things, you know, whether it's India or South Africa or Germany or the NHS, the Canadian system, they all have little snippets of stuff because it works. But again, they haven't put the whole system together.
I understand. I keep sitting on my hands. I want to say so much, but I really believe in what we're doing. So
Well,
I
come
just wanna
back
make it
again.
clear.
We'll be meeting here again next month, and I would like to, you know, see if we could have some of the people on our board and whatever talk with you also. So let's keep connecting, and we can go from there. But thank you all for coming. This has been wonderful. Kim?
Yeah, I just want to say, Matt, I saw your interest. So please fill out that jot form that Leanne put in the chat, and then we'll make sure that gets to the right person so that we can put you on the right committee, you know, to help move this forward. Liz?
Also, Lily, and I don't know if you filled out that interest form, but you might want to do that so that that gets to the board members too and can see what you're looking to do. I've been telling them, but so they could see really what your background is. Liz?
Yeah, so it sounds like you're still in the process of gathering a lot of people for the committees, but I was wondering, is there an idea of timing as to when they'll start?
Well, that's going to be dependent on the people that we can get in place. We really want to have each of the committees formed, and so that they can work on their own going forward on the aspect that they're working on, and then connecting back to the steering committee and some of those, and we're not there yet. So we've talked to a lot of people, and so many people were like, oh my gosh, this would be fantastic. And then somebody has a stroke, or somebody, you know, something happens. And so that's kind of what's been happening. But, and if you also have not filled out a form, if you want to do that, that would be wonderful.
I have, that's what I
Okay,
was asking.
great.
Yeah.
All right. Thank you all. We will see you in a month. It'll be May 10th is our next, and the next open forum. Please bring more people. If you know of people, don't wait until the 10th. If they want to talk to me, just have them contact me on LinkedIn or leanne@onceanurse.com.
I can tell you I will not be here on May 10th. We're doing a baby shower for my daughter, but
Oh,
yes.
how wonderful. I didn't even know she was pregnant. That's wonderful.
Oh, yeah. Yeah.
Excellent. Okay. Thank you
Hi,
all.
Darlene. Hi,
Okay.
Darlene. I didn't say hi to you earlier individually. Hi.
Thank
Great to
you.
be with
Thank
you
you.
all.
See you. Bye-bye.
Bye-bye.
Bye.